Welcome to this special event on the political economy of universal health coverage, which is a debate that's happening as part of an all-day roundtable on the subject. I'm delighted to be here. I'm a senior executive editor at The Lancet. My name's Pam Dass, sorry, forgot to mention that. And as you know, The Lancet has contributed to the various dialogues and publications around universal health coverage, helping to build the evidence base as well as expressing our support for it. So I'm really pleased to be chairing this event and very honoured and humbled given the distinguished panel. Let's start. I'd like to introduce the panel. Here, first of all, on Skype is Dr. Ted Roth. Also, you'd like to be known as Dr. Ted Roth. Is that right, Ted Roth?
Yes, yes.
Hello.
Hello, how are you?
Very well. And
greetings from Geneva.
The new DG, of course, of the WHO.
Thank you.
And followed by Ted Roth is Helen Clark, who is a former Prime Minister of New Zealand and in these recent times has been the former administrator of the United Nations Development Programme and a passionate and staunch advocate of human development. And last but not least is Professor Amartya Sen, who's Professor of Economics and Philosophy from Harvard University and the 1998 Nobel Prize winner in Economics, who's long and convincingly argued over the inextricable link between health and economic development. So the way this session is going to run is that each of our panelists are going to speak for 6 to 7 minutes, and then I'm going to open up the floor for Q&As to all of you. So, Ted Roth, handing over to you.
Yeah, thank you. Thank you so much to Chatham House and to Professor David Heyman, Rob Yates, my friend, and Rob Evers, for the opportunity to join this conversation by video. First of all, I would like to extend my condolences to all those affected by the senseless terrorist attack in London over the weekend. It's really saddening. I'm sorry I can't be there in person with you all, but I really appreciate you for helping me this happen, at least virtually. As many of you likely know, achieving universal health coverage is my top priority as Director General of the World Health Organization. Globally, an estimated 400 million, approximately 1 in 17 people, lack access to essential health services. That's unacceptable and counter to the world so many of us envision, one in which everyone can live healthy and productive lives. But that statistics doesn't capture what universal health coverage looks like at a personal level. For those of you who heard my speech at the World Health Assembly, you heard me talk about a young man in the Dominican Republic who was on dialysis treatment. When I asked him how much it cost, he said he didn't know. It was all provided free by the government of Dominican Republic. The story of this young man also shows that the benefits of universal health coverage also extend far beyond health itself. One of the reasons I'm so glad to be on this panel with both Dr. Amartya Sen and Her Excellency Helen Clark, especially with Dr. Amartya Sen. We have something to share, especially in his previous articles when he wrote about Kerala, which when we expanded Ethiopia's universal health coverage, we used Kerala as an example, and even we brought tutors from Kerala, and I'm glad I have something to share with this great man, and that me and him actually put Kerala as one best example globally. And back to the young man, when I asked him what would happen if he didn't have the dialysis that he needed, he said he would be dead. Nothing is more stark than that. Because he has access to the care that he needs, he's hoping to become a doctor and give back to his community. We talk a lot about health underpinning all of the Sustainable Development Goals. But this one story about this young man so clearly, so crystallizes the human impact of universal health coverage, not just on health, but also on broader communities and countries. This example is incredibly important to me because the Dominican Republic isn't a rich country, but they are committed to universal health coverage, and they have found a way to make it work in their country. That's one of the primary messages I continue to stress. Every model will not be the same, but every country can find a model that works for them. And resources are absolutely essential, but we can't underestimate the importance of political commitment to this effort. One of the reasons this session today is so important. Every country needs strong political champions if they're going to achieve universal health coverage. The great news is that over the past few years, we have seen the political will for universal health coverage growing at a national, regional, and global level. The past two hosts of the G7 summit, Germany and Japan, have used their positions to advocate for quality and accessible health systems that leave no one behind. Last year, African heads of states declared universal health coverage a priority for their governments. And just 2 weeks ago at the World Health Assembly, there was a standing room-only audience cheering on the vision for universal health coverage at a signing ceremony for the Global Compact to achieve universal health coverage by 2030. But as the sessions today are highlighting, there is much more to do. And as I look to take over the World Health Organization, my commitment is that the WHO will continue to be the world's champion for universal health coverage. In my mind, this means 4 key things. First, we need to benchmark best practices across geographies and income levels. One of the reasons for the lack of political commitment is fear around concern that universal health coverage won't be sustainable. We can address that by showing where it has worked and how. The WHO can also help countries tailor best practices to fit their needs and make the case for the resources they need using these examples. And secondly, we can continue to stress addressing universal health coverage in pieces. We can start with primary care systems that meet the vast majority of the population's needs, then look to become more specialized, including the secondary and tertiary levels. Next, we need to build political action, framing universal health coverage as a rights issue. And we can also stress that it's a means to prosperity. The right to health is actually a means to broader benefits for communities and countries. And we need to repeat that over and over again as we make our case for commitment and investment. And finally, we ourselves need to be vocal advocates for universal health coverage. When I first built my platform for the Director General, there were some who discouraged me from placing universal health coverage at its core, fearing that I would lose votes. However, the victory was a landslide, as you have observed. So I believe that the world is committed to universal health coverage. Also, here is what I think. If there is something that we fundamentally believe is the right thing to do, we can't shy away from talking about it. Speaking out about it and championing it is the first step to creating broader momentum around it. I, for one, will continue to champion universal health coverage wherever I go as Director General of the World Health Organization. And I hope I have a chance to work with you all in this effort as well. Thank you again for the opportunity to join this important conversation, and I look forward to the upcoming dialogue. Again, thank you so much for this opportunity.
Thank you, Ted Roth. Helen, over to you.
Well, thank you, Pam, and can I congratulate Ted Roth on his election as Director General of WHO too. Well, my background obviously has been in political leadership with a lot of contact with the health system. I have been a Minister of Health. I've been an opposition spokesperson on health. I've been a Prime Minister with a big health program in government. And then the last 8 years looking at development issues generally from the position as head of UNDP. So our topic is reducing poverty, the case for universal health coverage. And let me start with the blanket statement. You can't eradicate poverty without access to universal health coverage. Poverty is multi-dimensional. Poor health is an element of that. For the poor with no social protection, no access to comprehensive health coverage, illness takes away earning power. There may be no social protection to substitute for that. And of course, illness may impose costs which are catastrophic and push a family which may have clawed its way back out of poverty, back down into it. People are very vulnerable to poverty without comprehensive health coverage and social protection. So to lift people out of poverty and keep them out of it, universal health coverage has to be part of the mix. Otherwise, the shock of ill health is going to keep people down in that poverty area in perpetuity. And one point I would make is that today's so-called rich countries by and large, put their comprehensive health coverage policies in place when they were not rich, when they were relatively poor. You know, we have the phrase, leave no one behind, as if it's a revelation today in the new global agenda. But in my country, we celebrate the 80th year of comprehensive social protection and universal health coverage next year. What prompted it? The Great Depression. And families so down on their luck, they had no dignity, no access to health care. It was about changing all of that, about leaving no one behind close to 80 years ago. So I very much frame health as central to development, not a separate silo of issues and policies. I am someone who, as a young health minister, was inspired by the Almaty Declaration on primary health care in the 1978 Declaration, and take a broad focus on the social determinants of health, which takes you into much wider areas than access and affordability of treatment, because in the end, a state of health and well-being is about having adequate income, decent housing, access to water and sanitation, the knowledge that is acquired through education, a clean environment, and peace. And let's not forget the importance of peace. Look no further than Yemen today, where war has destroyed the economy and services like health. Cholera is spreading exponentially. There's severe acute malnutrition and a risk of famine in a country that doesn't have a drought, but it has a war. So trying to achieve health in the absence of the basic underpinnings of it is extremely difficult. I think in talking about comprehensive healthcare, universal health coverage, we also need to look at other structural barriers which might impede access. And clearly unjust and discriminatory laws fall into that category. If we take HIV, if men having sex with men are criminalised in a society, what hope do they have of universal health coverage reaching them? If sex work is criminalised, how does one reach those key populations? If injecting drug users don't have access to substitution therapy, how do you bring people into the comprehensive coverage net? So to me, the rights-based approaches on these issues are absolutely essential. A word on the form of universal health coverage. I am an unashamed proponent of public provision and keeping it simple, funded through taxation. My country covers its system out of taxation. Others, like this one, have national health insurance, which is in effect a tied tax. I think universal systems are needed without complexity. And just a reflection as a New Zealander, never in my life have I felt compelled to have private health insurance, except living the last 8 years in the United States of America, where the insurance was so complicated. I think I used it once when I had an eye infection, and that was a nightmare, and I used to go home and get everything done there. So that was money down the drain for me, literally. Next point. I see health, like education, as just one of those quintessential public goods. Needs to be prioritised in budgets. Goes without saying that unhealthy and uneducated populations will not be particularly productive ones, nor the people particularly happy, and happiness is important. I think the economic arguments for investing in universal health coverage are extremely strong. I don't particularly like resorting to the economic arguments, but if nothing else works, the economic argument usually does. I think the first and compelling argument is actually about human dignity and capabilities. But for sure, for prosperous and successful economies and societies, you need healthy people. A word on preventing the preventable. I think the concept of universal health coverage absolutely must encompass this. The right to health encompasses the right to know the risks one is running of use of tobacco, alcohol, junk food. In the case of my country, exposure to the sun, because if you have a skin like mine and live in the far south of the world, you're very exposed to cancer by melanoma. Lack of exercise, risky sexual behaviour. People have a right to know, to be aware, to know how to keep themselves healthy and safe. And also coverage should include access to screening for the detectable and then treatable cancers. And I would just say on the non-communicable diseases, these are now so widely recognised as major development issues, not just rich country issues. It was very good to see the NCD summit at the UN several years ago giving profile to these issues. My summary point would be to come back to a point that Ted Roth made, the importance of tailoring the systems to the circumstances. You never start with the gold standard when you're poor. China's barefoot doctors were brilliant. How else to get the services out to the communities? Start with what is feasible at the community level with the primary healthcare services. Over time, things can be added on, but very much start with the basics. In the Pacific, for so long, there was training for practitioners in nursing and medicine, which was pitched deliberately at a level below what would have provided for registration in a developed country. The idea was to train the doctors who would be committed to and stay in the regional environment, and that worked to build up the skills base in the area. But start with the basics and invest in the basics like housing, water and sanitation, basic nutrition. These are the foundations of a healthy society. So those are some of the reflections I thought I would put into the equation. Thank you.
Great. Thank you very much. Finally, I'd like to hand over to Amata.
Thank you very much. We have had such excellent statements already that my job is relatively easy. I should not upset the apple cart. I guess that's what I should say. That is, let me say how, first of all, I'd like to congratulate Ted Roth too for becoming the leader of one of the major institutions of the world, which can do a lot of good. It does do a lot of good, but can do even more good than it has been doing. And we very much look forward to your leadership on that. And both his statements and Helen's have brought out some of the most important issues that we have to look at. I think going down to the fundamentals, we can, one of the points to recognize that there's nothing as important for human well-being as health. Helen said that it makes people happy, but it's a bit more than that. There are different ways of becoming happy, and some of them are illusory. Having good health and being happy for that reason is not. And it's so much so we don't see how much the language has been affected by it. When we salute each other, we often forget that saluto just means good health. And so when 200 years ago, Alfred Tennyson wrote to Virgil, I salute thee, Mantovano because he was from Mantua. He wasn't wishing Virgil good health, who had been dead for 2,000 years by then, but he was expressing appreciation of everything he did, including poetry, not strictly a part of healthcare. But it has got so ingrained in our mind that it's very difficult for us to dissociate the fact that saluting each other is ultimately wishing each other good health. And I think the centrality of health is the first thing we have to recognize before anywhere else we proceed. The second thing is that that centrality could be respected by offering everyone basic health care. I was delighted to hear. I didn't quite know the history of how it happened in New Zealand and what part the Great Depression, you said, played in that. But these are, of course, a major thing to happen in the world, and I think in this respect, Europe, now that there's so much skepticism about Europe, is worth remembering there's a European tradition too. And there were people who were not particularly left-wing, like Bismarck, was talking about this subject long before anything happened. And when, after the war, lots of things the war brought out. One of them was when Britain had the smallest amount of food per capita, undernourishment in Britain altogether went dramatically down, and severe undernourishment completely disappeared with the least food. What happened? Everyone was, through rationing system, offered some food at a controlled price. A lot of people were affording to buy food which they had never been able to do at the time of plentiful food around. And the wartime availability of healthcare for all also taught some lessons. Not surprising that things moved very fast after that. Now, I was absolutely thrilled that Ted Roth referred to Kerala because they, in the context of India, that's a very important thing. There the source was a little different. It was a more left-wing source, and it would be difficult to think of a time when the Soviet Union was a leading figure doing things, and one of them was basic education for healthcare and basic entitlement healthcare and education. And when the left wing, in fact the communist government, came in Kerala in 1957, one of the first things to announce was that they're going to have universal education, universal healthcare, when Kerala was the third poorest state in India among these 20 or 25 or so. And how could it afford to do it? I mean, they wanted to do it because it was part of their commitment. But one of the economic points, and maybe the only economic point I'm going to make today, is that you have to look at relative cost. Labor is the central factor of production in both education and healthcare. And these are highly labor-intensive things. It's one of the accidents of the good world that they are so, because a poor country may have little money to spend on education and healthcare, but it needs relatively little money too, since wages are cheap and all labor-intensive commodities, including healthcare and education, happen to be much more easily affordable. So Kerala went to universal healthcare almost immediately. The third point to make is that, and the results were great. The life expectancy shot up in a way that it didn't in the rest of India. If we now compare India with China, China is way ahead of India for the India as a whole and for most Indian states. And it's partly connected with the economic success, but partly connected with universal healthcare, where a same source of inspiration moved the early communist regimes. The healthcare might have been very primitive, but it was available to all. And so by the time the economic reform came in 1979, China was close to 70 years life expectancy already. Now, the only state in India which was above that of China was Kerala, and it still is today. And it also indicates how much you can achieve. If you look at other countries like Thailand, where they have gone for universal health care recently, you see the same kind of result happening. So it can be afforded and can be done and can have its result. And not just in healthcare. I mean, I think it's so central, the point that both Helen and Ted Roth made, that health is central to development. And that's not only because being worthy of being saluted, having good health and living long is itself good, but on top of that, it also does something dramatically good about economic development. People forget, why is it that Japan, from the period of Meiji Restoration in 1868, and then later on South Korea, Taiwan, Hong Kong, Singapore, China in a big way, combined with economic reform, which initially was done without the healthcare being priority between 1979 and 2004. For 25 years, China didn't make very much progress on health, life expectancy, just 1 or 2 years gain. But in 25 years, when China was going faster than any other country. But by 2004, I mean, I happen to go to China every year because I'm quite interested in seeing what's happening. So by about 2002, it was clear that they have recognized they made some kind of error. By 2004, they have went change. So what had fallen from 100% coverage in 1979 to 12% coverage in 1981 went back to 98% by about 2010. And now, of course, the gap between India and China had narrowed, and now it's beginning to go up again quite dramatically. So the achievement, and that played a big part in the economic development, judged even in other terms, GNP and so on. GNP is not in itself very important. On the other hand, it's one of the means of leading a good life. And the fact that health and education are such big components of that contribution is somehow overlooked by a lot of people, overlooked by the World Bank and IMF for a long, long time. And it's overlooked by many of the dialogues about development even today. Maybe that it's, well, healthcare is good for people, but it's, what about economic development? Once we grow rich, we are going to then do all these things at a later stage, which is just the wrong way of thinking about it. The whole of the progress of East Asia has been based on combining, making skillful use of market, and at the same time also covering everyone in healthcare and education. Kerala, to take on the story where I left it, was third poorest when it started. By now it's the richest state in India. And those who said that how could it afford it, and what about economic factors, what about economic growth, overlooked the point which there's no reason for an economist to overlook. There was a guy called Adam Smith in 1776. He was writing about this subject already, about why education and healthcare is very important. There's this lovely statement when we are all debating about whether the public share of budgeting should be cut and everything should be privatized. A statement from the Wealth of Nations, not even from the Theory of Moral Sentiment, which, by the way, I also strongly recommend people reading. But in the Wealth of Nations, he said, why is it that we want higher income and a good, successful political economy? There are essentially two reasons. It makes people richer, and they can spend money and get those things which they want, which some of us would describe as the capability to lead a good life. And secondly, it gives the state more money to spend on those things which state alone can do well. And he talks more on education than on health. On the other hand, it's the same kind of thing that we are looking at. So I think there is a lot of history in the world in terms of what happened in different parts of the world, a lot of history of thought about who said what. And I think what people seem to overlook, that those who don't want to give priority to healthcare, or as in the United States, to get people out of affordable healthcare into presumably unaffordable healthcare, it overlooks the fact that not only our theorists and economists and sociologists and political scientists have been saying this, But the experience of the world bring out how important, how first of all affordable universal health care is, and how much of a dramatic difference it makes to people's lives, and ultimately even in economic growth. I emphasize, you don't want to put economic growth as the end and health as the means. After all, health is the end and economic growth is the means. But there is a double looping that is, by better health, you also are more productive. And with more productivity, you also have even more money to spend on education and healthcare and other things. And other things that's coming up today now, for example, in British election also, whether higher education should be as itself an affordably free commodity to be offered. In Britain, this is thought to be a reactionary thought on grounds that if you look only at rich and the poor, it looks as if it's going relatively to the rich. But there's another way of looking at it. This is a social commodity. Should it be not offered to everyone, free, for the reason for which New Zealand went in that direction 80 years ago? Thanks very much.
Thank you. Right, I'd like to open up the floor. I've been told I need to work the room, so I'm going to do so and ensure a good gender mix as well. So questions, let's start with the front first. Yes, and could you say who you are, who you're affiliated to, and who your question's for?
Yes, hi, my name is Georgios Bambat. I'm a social impact economist. I have a question for Dr. Adhanom. It's regarding the impact that religious belief have on the spreading of best practice on medical education and healthcare, and how it's going to go about it.
Okay, thank you. I wonder whether I should take actually a few questions, given time is ticking away. Are there any more? I'm going to... A lady? No, you're not lady. Yes.
Thank you so much. I'm Charity Ngilo. I just want to congratulate Dr. Adam for having been elected the Director General of WHO. And we as African countries, especially developing countries, we are very pleased because we now know for sure UHC is going to find its way and it will be implemented as we always wanted it to be. Thank you so much.
Great, thank you. I'm going to go to the back. Yes.
Rodrigo Rodriguez with International SOS. As a strong advocate of universal healthcare coverage, it's been saddening to see that countries that are just in the first phases of rolling out have had a number of hiccups with actual implementation. How do you ensure consistency in terms of quality and governance for these new countries that are just beginning to roll out universal coverage?
Okay, great, thank you. And that would be for everyone, perhaps, to comment on that. Okay, Ted Roth, did you hear all those questions?
You know, the quality has actually declined, and if you can refresh them, and if you can check also your mic if it's really properly.
The quality of the mic, yes. Can you hear me now?
I can hear a bit, you know, it's just the echo. It's a bit difficult.
Okay, well,
I don't know what you can do.
Well, maybe I just repeat the questions, I think, given you can hear me. So the first question was about religious practices and how they sort of stand in the way in terms of addressing universal health coverage.
Religious beliefs, you said?
Yeah, religious beliefs and practices, and which currently, you know, with the sort of, I guess, you know, very political, turbulent environment we're in right now. But yeah, specifically religious practices. Have you got a country in mind, or just generally?
Religion versus application of best practice.
Yeah, religion versus the application of best practice around UHC.
Mm-hmm. Okay.
And then the second question, which is for you as well as everyone else, as well as Helen and Marta, is countries who are in the first phase of rolling out UHC. One of the problems that they're having is in implementation. How do we sort of attain consistency with quality and good governance for those countries that are just starting out?
Consistency with policy and what?
Sorry, on the consistency around quality of care and governance issues around UHC.
Okay.
Quality, access, governance for those countries that are just beginning to roll out, and so implementation being a bit of a stumbling block to achieving quality, access and governance. Shall I perhaps go to, Helen or Marta, maybe you might want to answer that, and then shall I come back to you, Ted Roth?
As you wish.
Or, yeah, I just was wondering whether you wanted to get your thoughts together, but perhaps if you want to speak on those two issues.
Okay. On religion and, its application, vis-a-vis application of best practices, my own experience is, first of all, it's very important that we use religious leaders to advance the health objectives that we have. I have seen it in my country when I was health minister. We involved almost all denominations, religious denominations, and they really supported us a lot. But we also understand that on some issues, our positions are not the same. So we respect when there are some things because of their own position that they cannot do, and then they respect also our position. So we cooperate on things that we can do together, but on things that they don't want to do, we understand, and they can stay away from something that they don't want to do. And the most important thing here is there are common positions on many issues. And cooperating on those common positions is very important. And there are some where we don't agree with them or they don't agree with us, and then we leave that. We don't put any pressure on them. So that kind of relationship actually helps, but we have to understand that they have to be major stakeholders. We have to believe that they're very important players, and we have to use that potential they have, but by understanding and also managing wisely the differences that we have. Then on the second issue for countries that are struggling, especially on the implementation of UHC, the most important thing is that there should be a political commitment. If the government and the leadership has political commitment to implement universal health coverage, it can also at the same time understand what it can do and what it cannot do. Then it can go ahead with what it can do and then mobilize support for the gaps that the leadership identified. And as what I said in my speech, it can also start with phased approach, giving what it can give now while also thinking strategically and delivering the rest through phases. So if there is political commitment, I think implementing UHC is not difficult. During my campaign, I have visited many countries. Those who have implemented UHC, it's not because they're wealthy. It's because of the political commitment they have. Of course, I'm not saying resource constraint is not a problem. It is. But if there is political commitment, there are ways of addressing even the resource constraint we face. So I think political intervention is important, because the problem with lack of implementation of the UHC is in the mind. It's the mindset, especially the mindset of the leadership. So if we can address that, we can move on. But the other important thing is political commitment should also be supported by clarity of what UHC means. So the political commitment should be to that clear understanding of UHC. For instance, because of lack of understanding of UHC, there are countries who are not able to implement it. And WHO can help on that, can really clarify what exactly it means. And it can compile best practices, benchmark best practices from different countries with different levels of economy, and then even political ideology. And then countries can select something that fits their situation, but at the same time, WHO can help them tailor those best practices, benchmark it to their situation. And then WHO, after these best practices are tailored, should not shy away from advocating for the mobilization of resources, especially for the developing countries, to implement the UHC. So WHO should be involved in all these phases. It should not shy away by saying, I only support technical guidance and so on. I believe WHO has also the responsibility of convincing partners to finance UHC, especially to countries who have serious resource constraint. So coming back again to where I started, I think it all starts with political commitment. If there is political commitment, the remaining gaps or challenges can be addressed. And that's what I have seen in many countries, including in my own country. Thank you.
Great, thank you very much. Is there anything else you'd like to add to that, Helen?
On the first question, what is the impact of religious, and I'll add cultural belief on access to services? Actually, I think it's quite profound. Profound as to whether women get access, profound around the whole area of sexual and reproductive health and rights, profound with respect to the LGBTI communities, whether they can genuinely access services if they're actively being discriminated against. And this is an issue across a very wide range of countries. You will be aware that one of the early decisions of the new US administration is to cut funding for organisations in the family planning sphere who may see access to abortion as part of the menu of services. And our sister agency, UN Population Fund, whose executive head tragically died the night before last, they just lost 30% of their funding as a result of that gag rule, based presumably on some religious belief. So I think it has a profound effect, and I think it is so important in health to put a distance between whatever moral and personal beliefs one has and what is right for the population as a whole. Being judgmental, moralistic doesn't work in getting comprehensive health care. My second point would be to very much second what Ted Roth said about the role that WHO and others in the development sphere can play to support the countries trying to roll out comprehensive health care. I absolutely think this is a time for South-South cooperation, exchanging relevant experiences. What has worked, countries can adapt, implement, innovate from there. But WHO should definitely be seen as a clearinghouse for what can work, what might be able to be replicated or adapted, and certainly as a cheerleader for mobilisation of resources. And for the poorest countries, where official development assistance from rich countries is still significant, I think budget support for rolling out this while countries get their own finances to a higher level is going to be extremely important.
That's right. Did you want to say anything, Amata?
Well, first of all, I'd like to very much support what Helen and Ted Roth said earlier, particularly the impact. I mean, religion, of course, has a positive side, and missionaries have provided healthcare in all kinds of places. On the other hand, the kind of role that it often played, particularly in today's world, whether we are dealing with Middle East or whether dealing with the United States, cutting off funding from Planned Parenthood and so on. I mean, this is really a major challenge to be looked at. Ted Roth's point about WHO and his role with the poorer countries was seconded by Helen. I think the English language is very limited, so I don't think there is a verb saying I would like to turd it, but I would like to turd it, if I may, and very strongly turd it. But I'll come back to the question about hiccups. That is about what to do. Did I hear that right? About some problems that they...
Yes, so these are countries that are just beginning to roll out, and they're having problems.
First of all, you know, I think, I don't want to play too much with the word hiccup, but it is the case that in medical experiment, when you're extending it, there will be mistakes. This whole idea that nothing other than the perfectly good has done a lot of harm. We've done a lot of harm. I've tried to argue elsewhere in philosophy, in the theory of justice, by talking only about the ideal state rather than how you can improve the world. A lot of the improvement may go with hiccups, and still things will happen. I mean, when you tell the guy, listen, you got rid of your cholera, and he said, well, yeah, but I'm hiccuping. And you might say, okay, you're hiccuping, but at least you got rid of your cholera. Now, there is if such a thing happens, I think we ought to be able to celebrate. We have to be discriminatory, seeing what's happening. That's the first point. That doesn't mean that we ignore them. We want to look at it, we want to scrutinize it, and there is an asymmetry here because the public projects are always assessed by public discussion, whereas private projects are often assessed by whether you're making a profit, and some of the profit may be earned in a very shady way about treating people, and we know from the insurance industry. And the famous article by Kenneth Arrow, possibly, arguably, certainly one of the two, along with Paul Samuelson, greatest economist of our time, as to why healthcare cannot be delivered well by the market mechanism. He discusses those arguments. And part of the thing is that we can't have this kind of dialogue about private care in a way that we can easily about the public hospital, because that's the way we monitor it. Having said that, the other thing to mention is that to have an open mind is very important. And here I sometimes part company with people who are on my side, as it were, wanting a much bigger, first of all, having in the United States universal health care delivered by the state, by a single payer system. But the big attraction of the Canadian system is that you don't, you provide it to everyone, which is the positive thing. The other side is that you're not allowed to have private medical care except in a very limited way, and private insurance only in 3 areas, namely prescription medicine, private rooms in hospital, and ophthalmology. Now, there are 2 issues here. First of all, if it is the case that somebody who is rich wants to spend money by doing an MRI rather than going to buying a yacht and going off to Acapulco and so on, why is it that pro-health people would say the Acapulco is fine, but buying healthcare is not? I think there is something terribly wrong in the reasoning in that. Canada survives because there's the United States next door to it. So that if we are Canadian rich and have the dilemma, which is not the dilemma that poorer people have in any country. Mainly you have the money, you have some illness, and what would you do? Well, you go to Baltimore, you go to Boston, and see what medical care you can get. If the United States became like Canada, you won't be able to do quite that. So, and also historically, a lot of the medical breakthrough has come on the basis of treating the very, very rich people. It's one of those oddities, like so many of the innovations for civilian life have come from military research. That doesn't make wars likable things. On the other hand, it is the case that we have to recognize that. So I think we have to be open-minded in this way. And it seems to me in some ways the European system has already developed in that direction, allowing healthcare for all. And maybe the borderline, maybe there should be a bit more quality care for all, a bit fewer queues and so on. One could argue that. And at the same time, not choke off other people's health expenditure on grounds that they're not entitled to have it. It's the negative side, which I think we have to examine. I say we because I'm an activist in wanting healthcare for all, on the universal healthcare, but we shouldn't, on grounds of having universal healthcare, not choke off extra healthcare on the part of many people and take into account history seriously. But in that history, the big story isn't the private healthcare. The big story is the universal healthcare provided by the state. The commitment, as Ted Roth said, is very important for the government to be committed to doing it. But then on top of that, there are finer arguments we have to deal with, the role of what private care would be. By the way, Kerala now, everyone has health care, and everyone can go for that. But now about 55% of health care is delivered by the private sector. Now, a lot of people wrongly read it to mean that that's what made a difference. That didn't make the difference. That is the float sum came on top of the healthcare provision for all. And there was a recent study in Harvard Medical School. Somebody finished a master's degree comparing the new government proposal and practice, that if you get complicated illnesses, then the government will buy you, will give you some 30,000 rupees to go to a private hospital, public too or private also, to get cured. Now, it turns out from his work that it worked extremely well in places like Kerala, where the basic health care is done, and terribly badly, because in other places like Madhya Pradesh, Bihar, UP, where you don't get the basic health care, then you get into difficulty, then you go into a hospital for a treatment that you should have got much earlier, which would have prevented you having to go to the hospital. So it's a complementarity that we have to look at. And there are a lot of technical issues to be faced, but nothing is going to take away from the point that both Helen and Ted Roth made about the need for the commitment of the state to provide health care for all.
Yeah. Great, thank you. Well, we're sort of running out of time. We've got 4 minutes. If there are any just very quick questions that can be answered quickly, I suppose that's probably not the case, but Anna.
Thank you very much. I'm Anna Marriott from Oxfam, and I also wanted to pass my congratulations to Dr. Ted Roth, and also to thank him for putting UHC at the core of his campaign and his leadership. So I will try and keep this quick, but we all know, anyone who has studied development or the history of global health, that under structural adjustment, many countries were pushed or influenced to introduce user fees as a condition of support from the World Bank and the IMF. Now we have a global consensus around UHC and the need to reduce out-of-pocket payments, but in many countries those user fees still exist, and we're seeing as an organisation every day on the ground the impacts of those fees, denying people care, impoverishing people, And even in some countries, people are actually imprisoned for not being able to pay their healthcare fees. So my question really is what you would like to see, what role you would like to see the World Bank play now in helping countries to remove those fees and to champion UHC and really galvanize that political commitment that we need to see change on this issue.
Okay, great. And quickly, Stefan.
Stefan Peterson, Chief of Health at UNICEF. When I was a medical student in Sweden, I met Håkan Hellberg, an advisor to Halvdan Mahler in the PHC era. And we came to discuss PHC, and he said, it's easier to say hallelujah than to do it. So my question now is, how can we do hallelujah this time if we didn't do it last time? And I have a hypothesis that if we have rights and entitlements now and that agenda, is there a need for accountability mechanisms to hold the duty bearers to account, which is certainly international community, it is governments, it's service providers, but it's also people themselves. Why am I overweight and under-exercised, for instance?
Right, gosh, these aren't easy questions to answer in 60 seconds. Would you like, Ted Roth, would you like to quickly comment on those 2 points? User fees and accountability?
Okay. I think World Bank, I have spoken to Dr. Jim Kim last week, and he's really ready to work on UHC with WHO, and I'm planning actually to visit him as soon as possible. And from their side, they're very ready to work with WHO, focused on UHC to help countries. And I know, not only now, but previously as Minister of Health, they have really contributed a lot to building our health system. So what's most important is now we have to sit down not only with the World Bank, but with other partners, and we have to commit to build effective partnerships and share responsibilities based on their comparative advantage that can help us to achieve our common goals. So we're working in WHO already. I have started talking to staff, and I'm trying to understand and, of course, educate myself. But I believe the way forward will be for WHO to build partnerships. I believe WHO is the undisputed leader of the global health agenda, but it shouldn't try to do everything itself. It should also learn to give away some of the activities based on the comparative advantage of other stakeholders. And then by building effective partnerships, all partners can march towards the goals they agree with and contributed based on the responsibility they share when we share based on our comparative advantages. So I think we need to take that approach. But partnerships should not be for the sake of partnerships. There should be clear goals, clear expectations per partner, and measurements as we go forward, and make every partner accountable. And World Bank, I believe, is ready for this. And most of the support from World Bank will be in mobilizing resources, but WHO can advocate in helping the World Bank to increase its envelope of funding that will spend on universal health coverage. Then on primary health care or universal health coverage, I think I said it earlier, political commitment is very, very important. And we have to start it at country level. And people should know their rights. I think grassroots approach is very important. And leaders can be convinced and deliver on this. By the way, those who cannot be convinced, then if this is the agenda of the majority of the population, then that could be translated into the outcome of any election in any country. So I think the grassroots and the awareness of the public at large and really converting that into movement is very important. And then at country level, I think all leaders should be sensitized, and especially in countries where we have champions. I was with the Uruguay president, by the way, this morning, a very clear champion. We can use these champions to influence others. For instance, Japan's prime minister is very, very active in this, a very clear champion on this. And there are many other leaders globally from Asia, Europe, Africa, Latin America, the Caribbean, the Pacific, everywhere. So we can use this to influence their peers and to start it at sub-regional political organizations and regional political organizations. And WHO should not really shy away from engaging these political organizations, political leaders. Normally, WHO meets with health ministers and really is very shy in reaching out to other leaders. But I think more support can be mobilized actually by reaching out to foreign ministers, reaching out to heads of states, and then using the champions to influence others, and at the same time, starting processes, not just in Geneva and New York, but to start processes at sub-regional level. It could be, for instance, in Africa, it could be in ECOWAS, it could be in SADC, it could be in East African Community, it could be in the central one, or in Latin America, it could be UNASUR rather than the whole Latin America. It could be in just Caribbean. And then that sub-regional political movement can go into regional political movement. And the icing of the cup could be in Geneva or New York. So we need to have a foundation, a movement that really has a foundation and some consensus globally. And WHO should understand that it's not just doing technical things, but it should also lead politically. And if there is a technical and political balance of leadership, and as I said, mobilization from country to sub-region, region, and global level, I believe that we can make progress. So that's what I believe, and which I have already started talking to. We have really a huge potential and many champions which are lining up to help on this and to make progress. But I am a very strong believer of the power of our society. And we have to reach out and really use that power to make this thing happen. First of all, it's a rights issue. It's not a waste. And it's also a means to development. And this has to be understood. And this is a fight that we must fight in order to achieve universal health coverage, not just the talk, but I think it's time to walk our talk. Thank you.
Thank you, Tedros. Marta, you had a few words. Why don't we conclude with you quickly?
Making points in negative time. I will try, but I think you have to go beyond the accountability issue. This is a big issue, and to raise it in the last -2 minutes is a mistake. It's just that accountability is very necessary for a reason that you mentioned, but it's not adequate. For example, no national health service could run only on accountability. Accountability is what happened in the old days, what used to be called work to rule. Work to rule is something which you would not violate any of the rules. But National Health Service doesn't work only on that. It works on people doing a lot more than that. I called my doctor the other day. She was going home at 5 o'clock, but there was something urgent. If she went home, there would be no violation of accountability. But by 8 o'clock, she looked through it and told me that she was better at giving medical treatment than historical research. But she had done the historical research. Here's the answer I was looking for. Now, this is not accountability. It's well beyond it. And I think the literature had been messed up a lot by just demanding accountability. That's not how we behave with each other. there was questions from Oxfam. I'm very biased since I was part of it at one stage. They don't work only on accountability. It's a sense of responsibility. You know, you have to go back to Immanuel Kant and so on, namely to reflect what is it that we owe to others, and not necessarily on ground that they would be similarly owed to you, a kind of balance. I think if I may quote an Indian author at last, namely Gautam Buddha, he said that there's something completely wrong about this reasoning, that I do this for him because he would do the same for me. Because you do it for him or her because you think it's good. And that's an adequate reason. You don't have to ask the next question if you're interested in Sutta Nipata, where he's talking about the mother caring about the child. It's not because the child will do something for the mother, but because the child cannot do something for itself, which the mother can. And that is an argument for doing it. Then he proceeds to develop the argument for animals and human beings and so on. But I think you're even more correct than you were claiming, namely accountability is part of that right-duty framework, but more than that, a sense of responsibility. And that's one of the reasons the education came in, why it's so important to live in an educated society, that people can discuss this, and whenever you see the impact of education in anything from gender inequality to anything else, it is because of communication, because of the questions that you end up asking. And that takes you well beyond accountability.
Okay, great. Thank you very much. Can we say a round of applause for